Good morning. Good morning.
Hi, morning.
Hi, I have Jignesh.
Yes, that's me.
Bhavin.
Yep.
Brilliant. Good to confirm that you can hear me and I can hear you. Hi.
Hi there, sorry.
Can you hear me, Amy?
Yes, I can, sorry, yes.
So if we give it a moment for the others to join in, I think there will be 8 in total. And then I'll just make some introductory comments and then we can get started. Hi, is that Dom? Can you hear me?
Yes, can hear you.
Excellent. I've got you loud and clear. Emma, can you hear me?
Hi, yeah.
Excellent. Kate, can you hear me? Hello, Kate, can you hear me? You're muted, which is fine if you want to be muted.
Yes, I can.
Excellent. Okay. So I'm going to start with a little bit of introduction and then we get into the posters. First of all, thank you very much, everybody, for joining us. We've had about 120 abstracts for EdPom this year, and Monty, Mython and I over the last couple of days have been going through them in sessions like this. But I must emphasize that we are learning by doing in the virtual world. So when we get to the end of this, any feedback on how it's worked for you will be very gratefully received. Thank you very much for submitting your abstracts in the first place, and then for coming along today to present your posters. What I'll do is I'll put it on a screen share. So this is being recorded, if you don't mind, which means that we can then edit it and put the abstract presentations online for the EdPom meeting. So people who come along next week to the virtual meeting will be able to see the abstract presentations and the questions. And the meeting, I guess you probably know, but the meeting effectively starts on Saturday with the broadcast of the pre-recorded lectures, which will be available from Saturday onwards. And then the normal EdPom timetable of Tuesday, Wednesday, Thursday is what we'll do with joint meeting with POETS, the Power Operative Exercise Testing Training Society, on Tuesday, Pure EdPom on Wednesday, and then a joint meeting with the new Centre for Perioperative Care, National Centre for Perioperative Care, on Thursday. So hopefully you will be able to join us then. Now I'm going to try, this has worked every other time, so it should work this time. I'm going to screen share, and I've got a presentation that includes all your posters, but I haven't got a list of the order, so if you bear with me, that should be it. Now, can you see, you should be able to see just a single slide which says EdPom Abstract Poster Forum. Is that correct?
Yeah.
Yeah.
Yeah, excellent. Okay. So, oh, hold on.
It says 9 till 10. So.
Yeah, exactly. It may be the wrong one. Okay, apologies. I'm going to come out of that. It's worked perfectly every other time. Exit show. Right. One moment, forgive the technical glitch. There we go. Welcome, thank you. There are the PDFs of your posters and these Zoom videos will go on our website. There are 6 finalists who are presenting live on Wednesday and Thursday. If you're a finalist, you will already know. So we've definitely been in touch and confirmed with the finalists. It was very hard to select 6 from 120, as you can imagine. And one of the things, to give you a bit of background on the AdPom meeting, one of the things that has come from us going online is that we're essentially, all the meetings are open to anybody in the world, wherever the meeting is held. So we've had meetings in Chicago, you probably know, in Dingle in the southwest of Ireland, and in Las Vegas before, and we're going to combine all of those so that people who attend all of them will be able to do so, and at the end of the year, if they register with the e-learning platform, have a certificate of perioperative care. So that's a sort of something in development. In terms of the posters, so they'll come up in order. I'll give you a moment to sort of compose yourself, given that you don't know what sequence they're coming up in. And then there's 6 minutes per poster, and the ambition really is for maybe 1 or 2 minutes for a brief summary, and then a little bit of some questions and some chat. I will ask some questions, but please feel free to ask questions of the other presenters. And the only request I make, and I'm sure you would have done anyway, but if we try and ensure they are constructive rather than critical. So off we go. First up is Dr. Oram.
Hi, I'm Sean Oram. I'm a CT2 anaesthetist in Merthyr Tydfil. And we went about designing an anaesthetic emergency trolley to combine the locations of everything you need to treat anaphylaxis, local anaesthetic toxicity, bronchospasm, and malignant hypothermia. Because we identified as part of our pre-survey that no one really knew where anything was. And if an emergency happened, then we'd spend an awful lot of time sort of running around and not being able to find anything. And then this could negatively affect patient care. It's generally been well sort of accepted. Everyone knows where it is, and it has all the equipment, including sort of drawing up needles, syringes, all the drugs that you could possibly want or need. And the guidelines are also included in there to make it simple, so that in a crisis, you know exactly what you need, what you should be doing, and it's very easy for someone to follow and read out those to you.
When did you institute this?
So we instituted this back in November, just before the COVID-19 crisis. And unfortunately, I guess, we haven't had to use it yet in anger, but we have done several drills using it just to make sure that everybody's aware of where it is.
So it was completely independent of the COVID situation, but
yes.
So I don't know, did you have a lot of COVID where you are?
So we had about 20 patients at max on our surge, but our normal ITU capacity is only 8. So double what we normally would have. That was just in the intensive care unit. And I think in the wider hospital, there's 3 wards full.
And were you having to put together, were you able to put together teams to, some of the bigger units have done around sort of intubation team, proning team, that kind of thing? Did you further develop the trolley concept towards that at all?
We did actually. So we ended up using some boxes for drugs, for emergency drugs, and everything for the COVID patients. So we had sort of like an intubation trolley plus also a drug trolley and sort of everything you needed to sort of transport patients in and around the hospital on those trolleys as well. But and the emergency trolley itself sort of can be taken to either our day surgery, our sort of main theatres, or down to our obstetric unit. Great.
One of the things that sometimes happens with these type of innovations, which I think are really good, is so someone like yourself, or you and your colleagues come along and do something like this, and then you move along to another hospital and then another hospital. How will you make this sustainable, as in maintaining knowledge and maintaining the trolley? Who's going to look after it?
So fortunately, actually, 3 of the other fellow authors are ADPs that work in Merthyr. So they have taken on that responsibility to sort of maintain and pass it along. So the ADPs and the theatre assistants and everything know exactly where this trolley is. So fortunately for us, if there was a situation, we just tell the theatre assistant, go and get the emergency trolley, and they'd come back with it.
Okay, so you kind of feel like you've integrated it into the fabric of the department as opposed to it being an extra.
Yes, exactly. Yeah.
Excellent. Any questions from others on the call?
I was wondering if you've got a next step, and particularly whether or not you might be able to interest other hospitals in your area in having the same trolley, so that you talked about rotating trainees. It might be something that would make it easier for people if it was always the same.
So we have actually sort of begun that process. So it's also present in the Royal Glamorgan, which is part of our health board, and I think they're talking about taking it to Bridgend, which is also part of the same health board. So, but in terms of doing it across Wales, I'm not sure whether we've got that far yet.
And do you have, how's your trainee network in Wales?
So we tend to meet regularly for regional teaching. So we tend to know each other quite well. So we'll see each other probably once every couple of weeks. And you get to sort of mix with sort of other trainees in other places. And because you tend to rotate between district generals and then also sort of larger hospitals, you tend to get sort of a big mix of people.
So that's a potential mechanism for looking at implementing this almost countrywide.
Yes, yeah, potentially.
And is it just South Wales, or is it North and South Wales together? Because they always feel like a very long way apart to me.
So it tends to be South Wales, which covers all the way up to sort of Aberystwyth, all the way down to Newport Gwent.
Right. Good. Any other questions from those who are on the call?
You mentioned that you'd run drills and things. Did you use any other training or anything for the trainees and the people using the trolley? Was there like an email to alert people to it, or a generic kind of lecture session first, or did you just run drills?
So we initially sort of sent out a questionnaire, which was fairly well sort of filled in, and then we emailed out to say it was present, and then also passed it through managers and everything, so that each person, say each in our theatre complex, so the theatre assistants, the scrub nurses, the ADPs all have like a monthly meeting as part of our audit cycle. So they all sort of were talking and communicating about that and had some teaching prior to its implementation.
Great. Thank you, Sean. I can see the timer. It's about to ping.
Well, thank you very much.
Well done. Great presentation. So if we move on to the next presentation, Dr. Turnbull.
Yes, that's me. So hi, I'm Amy. I'm one of the new FIYs from Glasgow, and I've been working with some of the team at the GRI, looking at patients proposed for major pancreatic surgery and those that were seen at the high-risk anaesthetic clinic over the last 3 years. So kind of on the background of this research, we know that over the years, studies have shown that preoperative cardiopulmonary exercise testing has been a useful objective tool in predicting those who will benefit most from high-risk surgery, such as pancreatic surgery, with those having a low anaerobic threshold more likely to have post-operative morbidity. And also in recent years, the markers of systemic inflammatory response have also been linked to outcome. And following on from some preliminary evidence seen in heart failure patients and colorectal cancer patients, that there's a relationship between the two. We wanted to explore this relationship between the preoperative markers of SIRS and CPET in this cohort. Unfortunately, in this cohort, there wasn't sufficient evidence to suggest a significant relationship between the two. However, we did find that those with a low anaerobic threshold, that being less than 10.1, were significantly less likely to proceed to surgery, and also those with a high neutrophil to lymphocyte ratio were much more likely to have post-operative morbidity, and also there was a significant, a low albumin was also trending towards significance in relationship to post-operative morbidity. So kind of in conclusion, a larger cohort is required to kind of identify optimum threshold values for both CPET and SIRS in a cohort of patients, and also we'd want to look in the future to identify if a prehabilitation programme tailored to both a patient's nutrition and exercise preoperatively will both increase and improve their cardiovascular fitness and inflammation in a cohort of these patients. So.
Great, thank you. So can I, did you, should we expect the inflammation variables to be associated with the exercise variables, or might they be looking at rather different things?
There's been some evidence, so in the colorectal cancer patients, they showed that increased CRP was found to be higher in those patients with a low anaerobic threshold. And also in the heart failure patients, it's been shown that those with higher higher lymphocyte ratios and higher neutrophil to lymphocyte ratios have also been found to be higher in those with low anaerobic thresholds. Whether obviously this is a direct relationship or obviously whether that's just an association, obviously is still to be, the evidence there is slightly lacking. So I think obviously larger cohorts in these types of patients, especially cancer patients, needs to be reinforced.
Yeah, I mean, I would wonder whether they are slightly different things, because you know, if they're unfit, you can treat them with an exercise program. If they're, you know, if they're chronically inflamed, there may be other interventions you want to jump in with, although exercise may also help. I just want, it'd be very interesting to see the sort of the incremental predictive benefit of adding one to the other when you get a big enough.
Yeah, definitely. I think also with the inflammation, it showed that that it suggested that inflammation might lead to cachexia, obviously, which then may impact obviously in these patients' exercise potentials as well.
Yeah, and it get interesting to see how it changes over time if you start, you know, changing those different factors. Any questions from other folk on the call? Does anybody else use, because I think CPET is, I'm probably biased because we have it locally, but I think CPET is relatively common, certainly has been in the UK in the last few years. Does anybody else look at markers of inflammation, like something like lymphocyte neutrophil ratios? Yeah, I think it's really, if you think, when we've been thinking about work to do with why morbidity is associated with long-term outcome, one of the sort of obvious potential mechanisms is activity. If you're rendered less active by your surgery, so you're stuck on the sofa not taking the dog for a walk, then that's a potential. But the other, you know, the notion of chronic inflammation as linking those two, and that can obviously be pre-operatively as well as post-operatively, I think is really interesting. And it is something that you know, we have drugs and other approaches to manage. What are you going to do next?
So I know one of the anaesthetists, Myra McAdam, she's going to do a master's in looking at comparing so exercise pre-operatively, but looking at the different types of exercise. So currently in our colorectal cancer patients, we do, I'm working at endurance on the bikes and the cycles pre-operatively, but we also want to look at HIIT exercising, but obviously we know that HIIT can actually increase patients' systemic inflammatory response to begin with. So we think it'd be quite interesting to look at long-term if HIIT exercise, although it increases acutely their systemic inflammatory response, but whether that has long-term effects on their systemic inflammatory response and how that then impacts upon outcomes.
Yeah. I mean, you could, for anybody who does full blood counts, which is just about everybody, will have you know, the differential, so you'll get the neutrophil lymphocyte count. So if you could reach out to other centers doing CPET and see if you could, you know, you could probably get quite a lot bigger numbers from other people's data sets if they were happy to.
Yeah, we've got a lot larger data set in the colorectal cancer patients as well. So I think we're going to then look at that and see if we can see a relationship in them, because obviously we'll have larger numbers as well.
Right.
Thank you.
Good luck. Good project. Next up is Dr. Patel.
Hi, I'm Jignesh. I'm a perioperative fellow at UCLH. And so I was going to present an education initiative. So most of our junior doctors are important in the care of patients undergoing surgery. Often they have the most contact with patients whilst their senior colleagues are in theatre or and often responsible for coordinating perioperative care on the wards. Furthermore, we hope that they are the perioperative physicians of the future. We also know that patients undergoing emergency laparotomies are amongst the highest risk surgical patients. So our multidisciplinary and institutional faculty delivered a half-day multimodal education program to second-year foundation program doctors with the aim of improving knowledge and confidence in the management of patients undergoing emergency laparotomy. And the learning objectives were mapped to the professional competencies within the foundation curriculum. As I said, it was multimodal, so we split the session up into pre-operative, intraoperative and post-operative phases of the patient journey, and we used lectures. So for example, we talked about the evolution of the national laparotomy audit, what epidurals are and what common post-operative complications occur. We had breakout sessions, so where we got small groups to practice calculating risk with the NELA calculator on their apps, on their phones. And then we finished the session with 2 low fidelity simulations to kind of basically put everything together. We used pre and post questionnaires to assess confidence with different aspects of the perioperative care. And the results really showed that confidence in the 6 categories kind of listed on the poster in blue at the bottom showed that in every single one of them there was an improvement. And I've used a word cloud here to kind of demonstrate. So we used a Likert scale or of ranging from 1 to 5, where 1 is not at all confident to 5 being very confident. So in each of those bubbles, you should see 30 words, or just around 30 words, which are 5 possible options for the 6 different aspects of perioperative care. And the size of each word should demonstrate how frequently that response was given. And you can see in the pre-course questionnaire, there's a lot of neutrals, maybe some not so confident. And in the post-course questionnaire, we're pleased to see that there were a lot more confident and very confident responses. So we were quite pleased with those results. What we'd like to see in the future is that I'm a fellow currently working in London, but I'm from Birmingham. There are other fellows who I'm working with, and we're actually planning to take this back to our own hometowns. So we actually had a session booked in the diary for April, but unfortunately the obvious happened. But there are plans to roll it out in Birmingham and Oxford as well. But the aim is to try and tailor it to the local emergency laparotomy pathway. Another future direction is to look at other high-risk surgical patients, such as the hip fracture group. And also what might be interesting is to do a bit of research to see whether what could be the impact of on-care processes, such as standards within the emergency laparotomy audit, from an education program such as this. Great,
thank you very much. So interesting, your comment at the end. One of the things I just scribbled down was hip fractures, and I wondered, what is your impression of the balance between how much of what you were doing was specific to NELA and the nuts and bolts of those particular risk scores, and how much of it was actually generic, if you like, good medicine about evaluating risk and having an approach to things that's much broader than NELA?
Yeah, so actually this session is an add-on to a session that's already been delivered. So this was delivered in Cardiff. In Cardiff, they already have a perioperative general session for Foundation Year 1 doctors. So the idea was that this then builds on that. So this did have an aim of really focusing in on these patients. So there was quite a lot of time spent on the NELA risk stratification specific to emergency laparotomy patients, but there are also some transferable things as well. And so, but also a key part of it was familiarising foundation doctors with the local emergency laparotomy pathway and really going through it step by step and what their role is within it.
Right, thank you. Any questions from others on the call?
Yeah, can I ask a question, if that's okay?
Sure.
I was just wondering, who delivered your teaching session? Was it from senior members of staff, or was it more near peer education? And was there any thought or rationale behind it?
I think we're fairly opportunistic here. So I said it was. I mentioned it was multidisciplinary. So the faculty were the local NELA lead. There were two of my perioperative fellow colleagues and local anaesthetic trainees. But there was also, we got a surgical trainee and a radiologist.
Oh, fab.
Brilliant.
I just also had a question, if that's all right.
Yeah, go ahead.
Just wondering if you took feedback from the doctors that had this educational programme from each part, like in terms of the lectures, the workshops and the simulation, to see if there was any particular bit that you found most useful in terms of like taking your programme on in the future, in terms of where you could maybe focus in more.
Yeah, really good point. We didn't ask specifically which parts they favoured, but we did also have a free text kind of box to say what went well, what could be improved. And I think the kind of the common theme that they really enjoyed was the simulations. I think trainees really like simulation. I think the challenge with simulation is that it does take time, and often these to try and get all the foundation doctors in one place at one time is quite challenging. Yeah.
Great. Thank you very much, Jignesh. Great project.
Thanks. Okay.
Dr. Balendran?
Yeah. So I'm Bhavin, one of the new F1s at Addenbrooke's, and so our post was on a case report regarding the perioperative management of a patient with Tangier disease. So it's extremely rare inherited disorder, about only 100 cases identified worldwide. Due to mutation in the ABCA1 gene, so that protein it encodes is responsible for intra to extracellular transport of cholesterol and phospholipids onto HDL. So when that's defective, you get reduced HDL levels, and then also accumulation of lipids in cells. So depending where they are, that causes the characteristic symptoms of peripheral neuropathy, get splenomegaly. You can also get potential ischemic heart disease as well. So our case was a 48-year-old patient undergoing an elective open splenectomy, and there were kind of several perioperative risk factors identified. So he had a very low platelet count of about 30, and there was input from different specialties, so hematology, metabolic, all during this time as well. So there was a risk of bleeding. He also had a significant peripheral neuropathy requiring careful positioning during the operation. Significant nasal columellar atrophy. So this was a finding that was also present in his sister. It wasn't congenital, it just developed over the course of his early years. But the surgery itself was largely uneventful. So there was induction with propofol, fentanyl, and rocuronium, and that was successfully maintained. He did require some platelet infusions, and after the splenectomy, the platelet count did pick up very well and continued to pick up after that as well, with no significant post-operative complications. And the summary of this was really, it's a very rare case which had successful management, and there's very low reporting of it in the literature from an anaesthetic perspective, even though there are quite a few kind of significant factors based on the characteristics of the disease that can come into play.
Great, thank you very much. And is this something that is there a special interest in Cambridge? Is it something that you as a centre see relatively often, or was it really a one-off that you reported?
Relatively one-off. So this patient, he'd had a previous quadruple bypass as well. That was at Papworth Hospital. He'd had no other surgeries or significant encounters, just with his normal kind of metabolic and heme follow-ups. So yeah, really is a rare encounter.
Recognising that they're not on the call, and we should be nice and polite about them, but which was the most valuable input in terms of the different specialists that were inputting, and how much of it was from the literature and going away look at the textbooks, and how much of it was from your colleagues?
So I think in the kind of in the like long-term lead up, it was more metabolic side of things, especially with the diagnosis. So it's diagnosed from skin samples and found excess lipid levels in the fibroblasts. But around the actual perioperative assessment, I think the most important input was from hematology. So they had the plan laid out for his platelet counts and kind of when to transfuse and the acute management of that. So around the surgery itself, probably hematology was the most valuable input.
Interesting. Any questions from others on the call, or even any experience of this?
I was wondering if I could ask a question. A really interesting case. It sounds as though with his previous heart operation and this operation that this might be a guy or lady who comes back for future operations. Is there anything that you would do differently, given kind of your experience from this case and perhaps what you might have heard from Papua?
So I think he'd had the bypass and this surgery. I think the operations themselves were largely uneventful. There was kind of a good plan in place. Platelets were transfused when they were required. So there wasn't, I think there's not a huge amount that would necessarily be done differently if you had a further operation. Just keeping a close monitoring, I guess with every case, you have more experience and more surgery experience of a particular patient, just to kind of bear in mind for the future.
If you if a future challenge was a procedure that could be readily managed with a peripheral nerve block, say a ankle procedure, and I'm not offering a right or wrong answer. I'm just interested. Yeah. Do you think you'd go for a block or a catheter local anaesthetic technique, or would you go for another GA?
I think the block would be riskier with potential hematoma and also with peripheral neuropathy, hard to kind of assess recovery. It's a hard one to weigh up if catheter itself would be enough or would go as far as the risks of a GA. I think he's tolerated GA quite well, so it could end up that's deemed the best option. But again, yeah, quite an open.
And the nasal columnar atrophy. Yeah, I mean, it obviously looks unusual, but were there any meaningful implications of that, or is it an observation?
So there was concern in terms of form impacts on seal during bag and mask ventilation, or with nasal cannula, if that would have a significant impact. But during the procedure itself and after, it didn't actually prove to be a significant issue. More kind of a rare finding that was also present in his sister, just to be aware of.
Right. Great. Thank you very much indeed.
Thank you.
Next presentation is Dr. Ali.
Unfortunately, that's Faheen Ali, who's got some problems with her technology, so she's asked me to talk instead, if that's okay.
Of course, yeah.
So my name's Kate Chapman. I'm somewhere in those many people listed on this poster. And I work as a staff specialist, which is a consultant equivalent at Westmead Hospital, which is in the west of Sydney. So it's a tertiary teaching hospital with a very large and expanding population and a very diverse group of patients. And we have had a high risk service for the elective surgical patients since 2016. So this poster describes a little bit of information about those patients. We looked at 2 years worth of patients attending that clinic, and we looked at them last year, so we had a year's worth of follow-up for every patient that we looked at. So you can see there were 235 patients described in this, and they've all attended the elective high-risk clinic, and the elective high-risk clinic essentially accesses a wide variety of specialties with much more time than the standard clinic, and really tries to operate on a very shared decision-making model. So people come to the clinic referred by surgeons with the expectation that they will talk about what the options are for their care, not with the expectation that they will necessarily have a surgical procedure to solve their problem. And you can see described in the table a little bit of information about the sort of patients that come to that clinic. We record various things. We record everyone's ASA. They have the Edmonton Frailty Scale done. the predictions for morbidity and mortality come from the NSKIP calculations, which are chosen particularly because our surgeons contribute data to that project and so feel that it's representative for our patient population. So the information in that table is split into operative and non-operative, so that's what the patients chose in the end, whether they chose an operative solution for their problem or a non-operative solution. So you can see that overall they're a pretty high risk group. 36% of those who had an operation were ASA4, 62% of those who had non-operative route were ASA4. And really the key things we wanted to highlight are in the discussion. So there were some important things we thought. I think we were surprised by how high the proportion of patients was that chose a non-operative solution. So a third of patients who come to that clinic don't have an operation. And we really wanted to know whether or not that is a robust decision. Do these people change their mind? Do they go on to simply have an emergency version of the operation a couple of months later? Do they wish they'd chosen differently and go to a different hospital or come to our hospital? And actually we found that with the year's follow-up, the percentage of people who reversed the decision, so they chose to have an operation but they didn't have one, or they chose not to have an operation and they did have one, was really low. It was, you can see it's 3 people in each group, so 2% and 4% respectively.
Great, thank you. Is that, you're finished? Yeah.
I'll stop there. Yeah,
No,
I think I could probably talk about it for a long time. Yeah, no, I think I'll stop there.
Okay, I mean, really interesting data, and I mean, actually consistent with quite a lot I've seen from other places that you know, patients, you know, and I guess we all we maybe think we're different from patients, but we tend to know our own minds pretty well most of the time, some of the time. What proportion of the Westmead patient population were cancer patients, or what type of surgery was it?
So I haven't got exact figures for that, but quite a significant number are cancer patients. However, there are also quite a lot of people having what would be considered to be relatively small operations. So lap chole might be an operation, but we see a lot of people with breast cancer, a lot of people with colorectal cancer, less typically ENT or airway problems, because those usually end up down a route where for symptomatic control they perhaps have an operative intervention. And people with esophageal cancer definitely come via that kind of route, and pancreatic cancer too. And part of that is probably also because of who we have the buy-in from the surgeons.
Yeah.
To the service.
So people within those numbers, people presenting for cancer surgery who make a considered decision with a sustained, you know, consistency of that decision that they do not want to proceed to cancer surgery. Which, I mean, which is absolutely considered. We find the same in Southampton. I've seen, you know, lots of other places, but it is against the received wisdom you hear from some surgeons of, you know, they've got cancer, we have to operate. You know, it's what they want. It's really interesting.
And there's probably more detail in it, in that the operative people may be having an operation that is a smaller or more palliative operation with fewer risks. So they may end up with a decision for an operation that isn't the original operation. And within the non-operative side, that obviously doesn't preclude them having something like radiotherapy for symptom control. Interesting.
And you're how trained are you? Know, there's a lot of comment about the fact that you need to be an expert. When I don't know if that's true or not. I think you certainly need to be informed and interested. How did you train your group, or have you been learning by doing?
It's quite a small group who have a particular interest, but I would say that people definitely have learned by doing. And I think people are at pains to make others feel that it's not that these are the only people that can do this. Yeah. One of the major benefits is the time and the attitude of the patients who come when they come to the clinic.
Really
do they
interesting.
attend the clinic just once, or do they attend multiple times?
So the majority of them come just once, but some people come more than once, and that's usually either because they ask to come again because they want a bit more time, and they want to have a think about things, or because there's something else they're going to have in terms of optimization or an opinion or a test that makes a significant difference that they actually want to talk about afterwards. They all come, they're asked to come with an advocate, so they're asked to bring somebody with them who can attend the whole meeting. So we don't find that people typically need to go away, talk about it with their next of kin and come back, because they usually bring them with them.
Great, thank you very much. Really interesting. So next up, Dr. Barlow.
Hi, so I'm MRMA course surgical trainee actually in South Wales. So we did a project looking at our post-anaesthetic care unit in the University Hospital of Wales in Cardiff. So the aim of it was to kind of examine the morbidity and mortality in our PACU patient cohort and try and identify some factors that would be linked to poorer outcomes and how we could try and improve these. So our PACU is located within our critical care footprint. It has capacity for 6 patients at a time. They usually have 2-to-1 nursing unless it's for head and neck patients with airways, in which case they pre-arrange a 1-to-1 nursing at that point. And the aim of the PACU actually, it was set up in order to reduce morbidity and mortality in high-risk patients that were having complex surgeries that are actually often cancer surgeries, and provide level 2 or 3 care for them, and try and prevent cancellations due to capacity in ITU. So it was something that people booked pre-operatively, obviously, to try and arrange that, and knowing the patients needed that care. So we looked at some data from over a year, so December 2016 to 2017, and most of the data came from the ICNARC database. But on retrospective review, a few bits were added that weren't collected originally in that. We had 513 patients that were included, as some had snuck in that had emergency care and had gone to PACU, so it's kind of semi-emergency care. So we actually excluded those patients. So basically, you can see from the poster what kind of results we were looking at. So we were looking at things like preoperative hemoglobin, albumin, to look at nutritional status, whether they have preoperative risk stratification in the form of CPET, as we've discussed on the talk previously, length of stay in ITU and in hospital, and then mortality and post-op complications. And for their post-operative complications, we used a Clavian-Dindo scale to grade them. And basically the results showed that actually, despite having quite a high-risk comorbid population going into the PACU from multi-specialties, there was a low mortality rate. So it was less than 1% at 30 days and 0.19%, so only one of the patients died at 90 days. But actually it did highlight quite a lot of areas of improvement that were needed, and a lot of kind of disparity both interspecialty and intraspecialty about what patients were having preoperatively. So it showed that I think a third of patients were anemic pre-op, or quite a few of them actually hadn't had a hemoglobin checked, and the same with albumin. Almost a third, just under a third, were actually had low albumins and hadn't seen anyone about their nutritional status. So as a result, with this data, we actually went to Welsh Government to show them the model that we use in our PACU, and they were so impressed by the low mortality and the good outcomes that they were getting. They've provided funding to try and expand PACUs across South Wales to try and implement this model. We managed to sort out a primary care pathway for pre-op community optimization to try and help the anemia prehab, to try and improve CPET testing in patients and nutritional status. And for the anemia, we also introduced IV iron therapy preoperatively to try and help that. And we're constantly ongoing assessment of data to try and feed back to the MDT in other ways we can improve this. And probably one of the biggest things that happened was the introduction of a PACU booking pro forma online for specialties to use to book their patients. Again, this reduces the cancellations, and it means that PACU know what capacity they have for these complex surgeries, so that patients don't get cancelled. And it also prompts people to request the relevant investigations and make sure that the patients have had the CPET testing, to try and avoid all this disparity in between specialties, to try and get the best patient outcomes we can. So going forward, we're actually further analysing this data a little bit more to try and do a bit of statistical analysis and have a look at some other areas within the data. And also we've been looking at the Apache scores of the patients to try and see, and we're going to try and compare it with other centres that do probably cancer centres, to try and look at their complex cancer patients to see how we differ and what our outcomes are like in comparison to theirs.
Great, thank you, Emma. Can you, it says multi-specialty, but so who was doing it? What sort of people and what seniority, and what were they doing?
So there's 14 surgical specialties that kind of came through the PACU. So it ranged from upper GI, endocrine, colorectal, head and neck patients for their cancer resections and flaps and things, orthopedics, cardiothoracics. There was a real variety of specialties coming through. And as I said, the head and neck patients, a lot of them still come back with airways in situ and things. So they're the ones that are really key, I think, in that, and really need the booking before, as everyone does.
Who's the on-site medical input?
So they get reviewed by a general ITU consultant twice a day.
Right. So the IT, and then the junior staff are.
And there's an ITU SHO and registrar that are based there during the day as well, but they do get an ITU ward round twice a day. Whilst they're there, and then obviously a surgical consultant, their responsible consultant from surgery, will also see them every day.
Got you. And are they presumably there are things that you won't do, so I mean, we do inotropes and pressors, invasive monitoring, NIV?
I think they can start them there, but if they're heading in that direction, then they try and take them over then to general ITU. And because it's within the critical care footprint, it's really easy then to transfer the patients as they recognise. And because they're getting the regular review, it's really easy to recognise that the patient is starting to require more, and try and get them over early rather than sitting on a ward, unfortunately, getting sicker and sicker until someone presses the alarm bell. So I think it's definitely something that helps.
Yeah, thank you, Emma. Great project. Thank you.
Thank you.
Dr. Knight.
Yes, hello, good morning everyone. So I'm another Welsh trainee. There's a few of us, which is good. So I'm a core anaesthetic trainee, and the project I've got a little poster on is a small part of a much bigger CPET sort of system that we're introducing into our trust. So I work in Newport, which is in the south of Wales, and we're an expanding geographical sort of area. We're building a new sort of central hospital, which has ITU and HDU, with sort of 2 district general hospitals, and then we've got another sort of rehab hospital which we do day case surgery in. Last year there was a lot of funding to get CPET testing started in our health board, and that got up and running in October. There were lots of hiccups at the initial start, but one of the things is we realised patients were turning up and they weren't really knowing what was the whole purpose of their CPET session. And the whole purpose was it was meant to be a really inclusive, meet the anaesthetist, go through all your medications, see where we can optimise and put them on an exercise bike. So we realised this very early on, and we got a load of consultants and myself together, and we decided to create a patient information leaflet. We also created new referral processes, but this project is very much just based on this patient information leaflet. We had the idea that if we could tell our patients beforehand what to expect, hopefully they would perform better, or at least turned up better prepared. For example, turning up with a list of their medications. So what we did is we looked at every patient who went through CPET from September to March. We stopped at March because we stopped CPET because of the pandemic. And we looked at we got all of their information and demographics off our clinical computer systems. And then we phone called them all. And we sort of asked them 5 simple questions. Number 1, did you receive a leaflet? Number 2, did you read the leaflet? And we wanted to make sure our leaflet accurately described the experience they then had at their CPET session. We asked them whether they found their leaflet to be useful. And then we also collected data of whether they actually went on to have an operation. The nice thing about it being a telephone phone call is we could also just speak to them, and they were free to comment on stuff they thought was rubbish about the leaflet, things they thought that was good. We'd actually previously sent out written questionnaires, but we were only getting 2 or 3 back to the department. So sitting down one day, I had a very exciting day, and I called all of them. So I managed to call 64 people and get in contact with them. So we got a response of 74%. 85% of them had received the leaflets. We had a big proportion of patients in January time, so following Christmas, who did not appear to have received any leaflets. Of the people who got the leaflets, 98% of them had read the leaflets, and sort of 96% of them then described that the information we had provided on the leaflet, which is very much where to turn up, what to expect, was actually what they received in their session, which was really good. 93% of the people who got the leaflet and read the leaflet also found that it was just, they commented that they thought it was really useful. So the main conclusions we sort of gained from this project is the introduction of the leaflet clearly made a difference to practice that we noticed as from the anaesthetic consultants running the CPET sessions, and patients who got the information and read the information seemed to enjoy having the information. There was 9 people I contacted, those patients from January who didn't receive the leaflet, and 100% of them all mentioned that they would want the leaflet. The other thing that we sort of noticed from patients being able to speak freely over the phone, so the more qualitative data, was that even though we explained that there'll be a tight-fitting mask, lots of the patients didn't quite realise that they'd have to have a mouthpiece and how invasive that would or wouldn't be for their CPET session. So we got this information. The leaflet's been doing fantastic. The things that we're going to edit now is in trying to inform people a little bit better that they will be having the mouthpiece so that we can measure their oxygen levels, etc., and trying to better prepare them. We also, after one comment, we will be looking at trying to make a video so that there'll be something that patients can access to actually visualize better what the setup and the scenario will be when they come for their CPET session. All of this is just to really make sure that patients are turning up to their appointments, performing to their optimum on their CPET test, so that we can make a really valuable decision as to whether we send them for their general surgical or vascular surgery at the centre which has ICU and HDU post-operative care versus one of the more district general hospitals where if a patient was to deteriorate post-operatively, they'd have to be transferred to another hospital. So yeah, by trying to better prepare our patients, we're both sort of protecting our resources, but also making sure that we identify the patients who might benefit from post-operative care. Thanks.
Great, thank you very much. I mean, you kind of touched on this a little bit because you mentioned videos. How much have you looked at other formats from websites, apps, all that kind of thing? And
yeah.
Also the language issue.
Yeah, so this leaflet is only available in English, which is one of the things that my fiance mentioned was a bit crazy as soon as we're in Wales. But yeah, we definitely need to look at maybe putting it into different languages. The way our booking process goes, we've done a lot of work with mainly the colorectal cancer nurses and the vascular specialist nurses who submit the referrals. And they all give their patients a verbal heads up, and they've all actually come and visited the CPET session, so they should be able to give them a verbal heads up.
Yeah.
But then it's very much just secretaries who book the appointment. So apart from the leaflet and in their appointment in clinic, when somebody says, we're going to put you through for surgery, you're going to go see the anaesthetists, the patients really don't get much information. What we do with our regional patients is we do have all of these videos which show them walking into the hospital and the patient experience, and that's had really good feedback. So it's definitely something that we want to be able to introduce for the CPET session as well. I think just being a patient being able to visualize that they're in the right corridor walking towards a waiting room just will really reassure them just before they sit down for their session.
Great, thank you very much.
Thank you.
Okay, and you won't be able to see it, but I'll say last but very much not least, Dr. Zikri. Is Mina Mina Zikri with us? I can't see. Hold on, I'm just going to. It doesn't look like she is because I can see who's. Okay, well we'll recontact and see if we can offer another opportunity. Thank you very much, everybody, for presenting. I hope that was useful and hopefully even enjoyable. any feedback will be very welcome, positive or negative. And if you don't feel like saying it in public or relative public now, feel free to email us. But very interested to hear your feedback.
I think this is a really good idea. I think I've learned more about other people's projects in this short space of time than having wandered around conference boards. So yeah, I think it's really good.
And should we? I mean, this is obviously a kind of private for the whatever. I think in total there were 8 of us at one point. Should we offer an audience to come and watch as well? I mean, I don't know how many people we'd get, but would it make any difference to you if there were unknown people, maybe 20 or 30 of them in an audience also watching?
Personally, I wouldn't mind. I think it's great.
I think that's a good idea. I think you just have to be careful with the whole background noise. As long as there's a way you can control the mute buttons for the audience and stuff, I think it would be good. Yeah,
well, we can work on that. And as it felt, well, let us know by email if there's no other comment. But I hope you've enjoyed it.
The one big thing from my perspective, it'd just be really nice to get the posters beforehand, so you can actually. I'm on a small screen, so it's quite hard to actually read the text. And if you got them the night before, that'd be brilliant, just to scan through them and.
Yeah, for your session, that'd be good.
Yeah, so a very good call, and a couple of other people have suggested that. And I mean, if I'm completely honest, it's because we're learning by doing this year, and it's we're a bit just in time delivery this year, so we may not have had everything set up. But I think if we know that's an ambition, we can readily do it in future years. So I think that's a really good suggestion.
I think this is like a really good format, because to echo some other comments, that I've probably learned more about people's projects than walking around a conference. And I probably wouldn't mind actually if the audience had a text box that they could write questions in. You could maybe ask some of the audience questions, because then you get some more things, or people asking things that they want to know about your project.
Great. It's always good to hear new ideas as well, because it gives you places to go with your project and places to expand it as well. So you can learn from other people's ideas for your work as well, rather than just learning from other people's work. It's good.
Yeah. Well, thank you everybody for joining us, including from, are you in Sydney at the moment? What time is it? You're muted.
Oh, it's
yes, I am. It's 8:56 p.m.
Oh, well, yeah. Very well done.
Stefan and I are both in Sydney.
Okay, I think you both earned yourselves a glass of whatever it is. It's your favourite thing. Thank you very much for joining us, and well, thank you everyone, and hopefully we will. I hope you can join in next week for the main meeting. So thanks a lot.
Thanks very much.
Thanks.
Thanks.